attendees are in listen-only mode.
Hello and welcome to the Practice Admin, first of our summer webinar series. And we're talking today about how to increase your bottom line through chronic care management revenue. And we have with us today Matt Ethington, the founder and CEO of Discharge IQ. Matt, welcome. Thank you for joining us today.
Thank you. Thank you, Tamara.
Okay, we're going to give people another minute to join us and then we will get started. And please, if you have any questions, just type in the questions and I can see them. Again, thank you for joining us. We're giving people another minute to join us and then we'll get started. Okay. And a reminder, this webinar is being recorded and will be available on request as well as the PowerPoint. I know I often get requests for the PowerPoint. A lot of great information here that you'll probably want to share for billing customers or billing companies with your clients. All right, so let's get started. Again, Matt, thank you for joining us. A little bit about Matt. Matt is the CEO and founder of Discharge IQ, which is, we'll talk more about that. And he is a successful entrepreneur and health IT leader with a great history. He also founded the award-winning Simplify MD. Matt, again, welcome to our webinar today. We're so happy to have you to talk with us about this really interesting topic on how physicians can generally increase their revenue through this new program.
Well, thank you. I appreciate it, and hope I can be of service to these good people that have joined us.
Great. Jumping in very quickly to our agenda, we're going to discuss about the actual program. There's a lot of questions about what is it and why should I know about it, why is it important, how you can participate in it and get started, and then some information from Matt about Discharge IQ and how it can effectively help you with the program. And then sort of what do patients and doctors need to know about Discharge IQ. So with that, let's launch into CMS CCM incentive program. First of all, it was effective January 1st, 2015. And many of you may have heard of it, but really haven't had a chance to sit down and understand what it is and how it works. Essentially, it's a $42 per month for 20 minutes of non-face-to-face chronic care per patient. Now, if you add that up, let's say you're a cardiologist and you have 300 chronic care patients. So that adds up to a significant revenue annually and monthly to your practice. So here's some basic facts about the program. Matt, maybe you can run over and dive into some of these a little bit for us about what this is all about.
Yeah, thank you. So the first thing I think I would probably say, Tamara, is that the CCM program itself was a 3-year initiative, and it is one of the payment reforms that were mandated by the Affordable Care Act, and it falls in the Federal Register in the same category as the Affordable Care Organizations and the Patient-Centered Medical Homes. So it's been a huge commitment of the federal government to migrate, or I guess to begin transitioning our fee-for-service structure of our healthcare system into what they call fee for value. So it is a financially tangible part of the commitment to change how healthcare is paid for in the U.S. And then the program itself, the individual requirements, which we can go over and of course we'll make available, in handouts and resources. Those individual items were kind of figured out over a series of in 2013 and 2014 in a couple comment periods, etc. And the program, as you said, reimburses doctors for 20 minutes of non-face-to-face care for patients that have 2 or more chronic diseases. And it can't just be any chronic disease. It does have to be something where the patient is at benefit, or I'm sorry, at risk of decline without attention to those particular issues. And it's, the people have talked about a lot of different ways. They've talked about, okay, well, this is to reimburse primary care who have been the librarians for these patients that, whose care has to be coordinated by, maybe they see multiple doctors, that type of thing. It's been explained as a bridge, as I kind of just explained it, from fee-for-service into fee-for-value. So it's really part of a larger initiative, and it's very financially tangible to the doctors and practices of the overall migration of healthcare.
Right. And quick note, if you go to practiceadmin.com, we actually have a white paper brief on the information that's in this webinar, but this is information directly from the CMS site, and it also includes a sample patient consent form. The CMS does not provide the consent form, so this is just a sample for the physicians to work from. So I encourage people to go to our website to download this white paper. I'll also include a link in the follow-up email after this webinar. All right, let's move on to the next. So this is talking about, again, why is this program important? As Matt, you were just discussing a little bit. Another reminder, in the white paper, there's a link to the chronic care catalog, essentially. I think it's with CMS. So there's a link to that there for which chronic care diseases actually qualify for this. All right, Matt.
Well, the CCM program well, I've worked in ambulatory care for a long time, and we see doctors today, seeing twice as many patients as they did just 10 and 15 years ago to make the same amount of money.
Right.
And so I think it is important because it's a financially meaningful opportunity for a physician to or a practice to earn additional revenue. It's getting harder and harder with all of the regulations and meaningful use and buy-in EMR and all of the things that that are laid on the backs of physicians, in particular primary care, that it is an opportunity for them to earn additional income. And I should also want to make the statement that it is not the primary burden of the CCM revenue model does not fall upon the physician. A certified medical staff, so a medical assistant, a nurse, etc. It's anybody that works under the general supervision of the physician can qualify 20 minutes per month per patient, then they enable that reimbursement. So it's not as if we were saying, okay, well, there's this much extra work for the physician. That's not the case, although the physician is obviously responsible for the care his practice provides. It's not 100 more office visits. And I really can't think of a time in the 20 years that I've been involved where an opportunity like this has come along. So if you can do a quick analysis of patient panels, et cetera. Let's say there's 2,300 patients in an internal medicine and family practice panel. Well, internal medicine, 40% of those patients are going to probably be Medicare. And I'm speaking to a lot of people who know these numbers better than I do.
Right, and these, in fact, these stats
but
are
we're
pretty
getting
significant.
around 600, 1,000 eligible patients, and then Medicare is clear that 68.6% of their beneficiaries are eligible. So you can easily see how you can get to 700, 400 patients.
It's going to
even
increase.
in a family practice. Yeah. So, and that at $42 a month times 400 patients, sizable.
Right.
Over $150,000 a year, and if only half sign up, it's
yeah.
75 grand a year. So
now,
that's why I think it's really important.
Top bullet here. I was talking to a neighbor and friend the other day who works at CDC, and he was saying it's now actually 86%. They just released a new report at CDC, which I cited recently in our blog. So it's going to continue to increase.
Right. And here's another reason why it's important is I think it's a model of care.
Yes.
So, look at how many of us have smartphones. And I happen to be a chronic patient. I developed type 1 diabetes at the age of 30, 15 years ago. So, and managing a chronic disease isn't any fun. But if you look at the standard model of managing chronic care, patients, diabetes, et cetera, I go in once every 3 months, and we run a blood test called an A1C hemoglobin that gives a basic analysis of how well I've managed my blood sugar over the prior 3 months. And then the doctor and I make changes about how I'm going to do it for the next 3 months. Now, so I want to ask all of you business people out there, could you imagine running your business on one metric over 6 months? And so finally, with the advent of smartphones and things like that, we have patients carrying around technology that we can leverage to help them manage chronic disease, help them be more healthy. And I think this is probably a unique time in the healthcare industry where this technology is now adopted, and yet it's not in use. And I think that in a few years we will remember back to when people weren't more engaged or interactive in their chronic disease management.
Right, and I think you were telling me that of the Medicare patients this impacts, there's to a certain extent, I forget what the percentage was you quoted to me, maybe 40% do not have smartphones yet, but that's rapidly changing.
Well, so the groups that we're talking, it's closer to 50-50.
Wow, yeah.
And in fact, we were working with one of our clients yesterday. Interesting. He had 3 patients, 3 Medicare patients that were going out to get an iPhone that day because
Wow.
he showed them a product that they could
Really?
use to help keep him informed. Yeah, and so think about it from a patient standpoint. If you do have a chronic disease, it is kind of scary,
Yeah.
and then you may be, you might not have a big support team around you, or even if you do, it changes the game a little bit if you're actively engaged with your practice, and it gives the patient a little more security to know that there's some care management happening.
Oh, definitely.
And it's good for patients.
So it's become a lifeline, in effect, having your smartphone with you for everything.
Well, yeah, and by the way, smartphones aren't part of the chronic care management program.
Right.
They're part of what we do. We'll talk about that in a little bit.
Yes.
But the chronic care management is a reimbursement mechanism to get practices reimbursed for the work they're probably already doing.
All right, let's move on to the next slide. So this is, let's say you are interested in participating. You understand now the significance and the incentives. Where do you start? What are you going to do? The first step is to identify those patients that qualify. Can you take it from there, Matt? Let's see, we've got...
Yeah, so I think the first step for everybody listening ought to be to get a good review of what the program requirements are. And we have information about that as well. So it's not as simple as, I spoke to the patient, for 20 minutes the other day, and so I'm going to mark them off and bill them. There are some specific requirements that have to be met. And we'll go into this in a little more detail as well, but I want to urge everybody to pay special attention to those requirements, because if you take the Medicare beneficiaries and you multiply the number that are eligible for this program times $42.60 times 12 months in a year, and you'll see that this becomes a $17 billion expenditure on the books for Medicare. And typical to many things they do, Medicare throws the money out there, let's get the program started, and then they chase it with auditors.
Right.
So that's why I would just urge everybody, take a good look at what the requirements are. So before we start signing patients up, we want to make sure that we meet the requirements. So the first one, right off the bat, is that the patient must have a 2011 or a 2014 certified EMR. here's the catch.
Mm-hmm.
They don't really have to use it, but they have to have one. They don't have to be certified, or they don't have to be, have meaningful use, but they have to have that EMR, and they have to create something called a care plan. And a care plan is basically what are the goals for this patient. And that care plan has to be shared. They don't say how. They just say that care plan must be shared electronically, but not via electronic fax, with other members of the care team, as well as the patient. You can also print out a copy of the care plan and give it to the patient. But so there are more than a few requirements. You have to be available to the patient 24 hours a day, 7 days a week. Now, what that means is, before everybody gasps and takes a deep breath, that's an on-call service. Essentially, most practices already meet that requirement. You must be able to document the 20 minutes. Where did you spend the 20 minutes? What were you doing? You don't have to document that on your claim. You just have to, when you send the claim in, you're attesting essentially that you've done that. Two things that are a little bit more difficult to define. You have to facilitate a transition of care. So, a transition of care would mean a heart failure patient coming out of the hospital. They have metrics that they like to measure. Was the patient called within 48 hours? Was the patient seen within 7 days? That type of stuff. You are supposed to, or you're required to help transition that patient back into their or into their prior environment or into their new environment. And then you're supposed to coordinate the care among the other care providers on that patient's team. So there's a lot more information about what all that means. But just be aware, there are requirements. It's not exactly free money. But it is work that the staff's probably already doing.
Right. And I know one of the biggest challenges from what I've heard and talking to you and other people is this patient consent form. Getting the patient on board with it and the value of it to them, and then to get them to actually sign the form. And the CMS doesn't actually provide the form, but as I said in our white paper, we have a sample of what that form should look like.
Right. So it is a challenge, and to just kind of evidence of that challenge, I'll talk about a practice that I was visiting with the other day. They thought that they would have about 1,000 patients enroll. And they're enrolling these patients. They do this manually with an Excel spreadsheet to document their time and get the forms and scan them into the EMR and that kind of stuff. The challenge that they have is if you could imagine sitting down and talking to a patient and say, we want to enroll you in this Medicare program. If you don't have subsequent supplemental insurance, we're going to bill you $8 a month. And what it amounts to is we're going to what? How do you explain it? We're going to call all your other doctors and make sure they all have the right list of medications, and we're going to be available to you anytime you want to call us. It's tough because it's hard to talk about what exactly.
What's the value to them?
Well, what are you putting in their hands that they don't have today that they're going to buy? So people are just kind of like, well, I'm not so sure. And so this particular group had less than a 20% take rate on patients they thought for sure would say, yes, we want to do this program. And it's not because it's not a service, it's something that they're not doing. Patients think they're already getting it anyway. So why am I going to sign my name on something?
Right. And I suspect that's probably one of the holdouts for people.
Well, and we're still early. I mean, we're still way early into this program. But that is where having a product that helps do chronic care management like ours is helpful, because it's something that you can show the patient and say, we're going to give you this. We want you to answer a few of these questions every day, and then we're going to do this, this, and this, and we're going to keep an eye on your care. Well, then it becomes something that you can say yes to.
Right. Now, the CPT codes, I know that the 99490 code is pretty much assigned to chronic care. I haven't heard any latest updates on, there was some question about if they're going to bundle the 99487 and 99489 code. I haven't been able to find any more updates on that. So,
and I don't know a lot about
yeah,
those codes.
yeah. I was going to suggest again, in the white paper, we have a little more information on that, as well as links to the appropriate CMS information and other sites to get more information on that.
Tamara, are those when you spend more than 20 minutes?
I am not sure either. It outlines it more in the description for each of the codes.
Okay.
So I've got that in the white paper. All right, let's go on to the next. So Matt, I know we've kind of led into this, exactly what is Discharge IQ, and as we've just seen and heard, managing the program can be challenging, as well as getting the patient's consent. So what is Discharge IQ, and how can that help these physicians get the patients on board using it?
Sure. Well, Discharge IQ is a software platform that manages the requirements, the enrollment, etc., of the CCM program from end to end. So it is a turnkey program that helps to get patients enrolled, manages the CCM execution, documents all of the compliance, creates the necessary audit reports, and enables a practice to perform CCM at scale while extensively documenting compliance with the requirements. So it is a way to do this new Medicare program in a fashion that gives the doctor the most security at a scale where the revenue can be meaningful.
Now, I know the CCM program was launched January 1st, and as you said, we're still early on. I'm going to go on to the next slide because you were explaining to me how Discharge IQ was essentially developed in advance of this with clinical protocols. So could you sort of give us a little bit of insight on why you developed this? And I know also from a personal reason why you developed this.
So it goes back to a little bit of hospital readmission. A shocking number of patients must be readmitted to hospitals. 1 out of 5 American seniors that's discharged from a hospital goes back within 30 days. And the number around heart failure is even higher. It's 1 out of 4. And so as I was analyzing that problem after I left the EMR business and had some exposure to telemedicine and was talking to different doctors, like, well, why does that happen? And it could happen for any one of a number of reasons, but they can't be predicted. And if they can't be predicted, they can't be prevented. So I started thinking about, well, how do I get close enough to the patient after they're discharged to know and to get an accurate risk assessment of who might be headed for a readmission. And we thought, well, what we need is an app on a smartphone where a patient, it has to be really easy to use. It just asks a few questions every day, and then we can use those questions and we can trend them to see how that patient's recovery is taking place. And while doing that, because I manage my own type 1 diabetes, I thought, you know what, I'm going to start putting in my own metrics for my own diabetes because I don't like writing them down. So all of that was taking place, and we were, active with some hospitals and talking about rolling this out to their hospitals. And when somebody pointed out the chronic care management code to me, so we had already built this program to manage specific disease states. So if you're discharged from the hospital with cardiac failure, there are certain key metrics we want to know every day so that we can predict if we might need an intervention by analyzing those metrics and how they're trending over a subsequent number of days. Another thing I'm going to need to do is make sure that that patient is getting back engaged into their mechanisms of care, that they are going to see their doctor, that the goals for this patient are clearly outlined in something called a care plan, and that their care is efficiently coordinated and tracked so that we know that patient has been back into primary care, so that we know that they're taking their medication, so that we can, we can make sure that we're risking or we're identifying any areas and eliminating any areas of risk. So we really already had a care coordination tool and a disease management tool, which is essentially what the chronic care program is from Medicare. It's to coordinate the patient's care and help manage chronic disease patients. The 85% of our healthcare spend is on patients with chronic disease.
Right.
And the part of this, the Affordable Care Act was to talk about how do we shift from being reactive care or sick care to proactive care.
Right.
And so the model of what we were doing really fit into what they were switching over to the ambulatory side, and that is coordinate care and help manage patients' chronic disease. And since I had the background in technology background and the background as a chronic patient, I thought, you know what?
Yeah.
Let's do this. And so we leveraged those skill sets, some members of the team. We added all of the audit things. I think probably the worst thing that can happen to a doctor is trusting somebody to come in and help their business, and then that product just disappearing or exposing them to risk. So we wanted to make sure we could meet all of the audit requirements and show them how they could easily accomplish those things.
Frankly, I was kind of amazed when you and I started talking, because it seems like such a simple concept. I would have suspected it would have come along before now. So I think the timing is really great for this. And just looking at it, let me go on to the next slide, in fact. It's all right here on your smartphone. There's nothing to buy or install, no Bluetooth. It's very easy to set up, and it's mobile, very mobile. So I was amazed that I could, like you showed it to me, it's just a series of questions, and these are, as I see it, very standard diagnostic questions which are accepted within the clinical by your doctor. So can you tell us a little bit more about that, Matt? How does a patient use this?
Well, there's a secret to working with patients that have chronic disease, and quote unquote, there's a big industry buzzword which I detest, and it's called patient engagement.
Yes.
Like, how do we engage patients with chronic disease? How do we get them to participate? And the secret is patients with chronic disease don't want to be engaged. They want to be divorced.
Yeah.
We live with, we eat, breathe, sleep, wake up in the morning, go to sleep at night, and get a drink of water in the middle of the night with our chronic disease. And so to take a patient like that and say, okay, well, now I want you to track this information in this logbook, and then I want you to write it all down, and then I want you to bring it into my office. When you come back 3 months later, it's a burden. If you say, as many EMR companies are trying to figure out how do we bridge this gap, because chronic care isn't anywhere near, it's not even mentioned in the entire meaningful use federal records. So it's unrealistic to think somebody's going to sit down, log into a patient portal, remember their username, remember their password, reset it if they have to reset it, call whoever they have to do that, to go in and find some place to record something. It has to be an almost passive activity to get patients engaged. So when we talked earlier about how do we get people to sign up, well, we show them something. We say, listen, if you'll do this, patient, your phone is going to go off at a certain time in the day. It's going to ask you a few questions that you can answer. Shouldn't take you more than 15 seconds. Perfect. I'll do it. It has to be a passive activity. So we increase the patient engagement with that so that the doctor can actually be monitoring more patients. On the backside, part of that is it has to be easy for the patients so they don't drop out. And the third thing about the product is that it's very customizable. It's also very mature for what it is. Like you said, there are certain well-accepted standards of chronic care. And so in working with our medical team, we identified what those were, and we made them into protocols to query the patient. And so it is a customizable platform where a patient may get a few questions today, may skip a few days, and then they get 5 questions a few days later. So it really kind of zooms in and is relevant to the individual patient, and then it gives the metrics back to the doctor. in a fashion where they can quickly identify which patients in their practice are at risk.
Right, yeah, which is great.
And so that's helpful. And, you know, we have to meet 20 minutes a month in time with these patients. Now, monitoring patients is actually approved by CCM as time.
So this covers that requirement for the program as well.
It does. It does. It's so what by just interfacing with this app, and patients don't have to have an app. We all have elderly patients in our practices
right.
that, you know, there is no technology, period. Technology is maybe they have a cordless phone. So, you know, for those patients, and you want to enroll them and care for them and monitor them, and of course you don't want to forego the reimbursement if it's available, you can actually subscribe. The doctor can say, okay, we want to monitor Mrs. Johnson for stage 2 heart failure and hypertension and moderately controlled type 2 diabetes. So you can actually monitor that patient. Just call them and ask them the questions that the smartphone would normally ask them, and then document it for them. And if they wanted to log into a computer, or this is helpful. I was shocked. I was having a conversation with the director of healthcare for Intel a couple weeks ago, and he said seniors are one of their fastest growing market demographics.
I believe
and they're creating tablets for seniors that have large windows, large fonts, etc.
Oh, that's awesome.
And so and Dr. Alan Einstein is his name, told me the other day that that he was telling one of his patients about how Discharge IQ would work if he'd used it, and he didn't have a smartphone, but he had it as an iPad.
Right.
And so, you know, we gave him the instructions on how to download the app, and he said, I know how to download apps.
Yeah.
So tablets, at-home tablets, that came as a shock to me, but that is another way to use the product. So we did make it easy for the practice to enroll as many as possible. You can call them. They can download it on a tablet. If they want to log in through our portal on the web, of course they can do that.
Right.
Or the one that I love is smartphone, because it goes with the patient, and it's almost a passive activity at that point. It buzzes, you answer the question, you put it away.
Now, interestingly, I heard an article on the radio this morning on NPR about the Medicare was testing a program, I think it was in California, where they were assigning, it sounded like nurses or on-call nurses to certain Medicare patients to engage them more with those Medicare patients in the same way. They would call them daily and ask them questions and record the information. This is a test program, but if they were to implement such a program, the cost would be immense. Whereas something like this, I would see more as a bridge or a gap to actually having a person, but this information is going directly to your doctor. Anyway, I just thought it was interesting. I heard about that on NPR this morning.
Yeah, so they've tried a lot of programs. The interesting one is, you know, and they call some monitoring, and then this is really, I think, physician-proctored patient monitoring, because what we're doing is we're only passing information to the practice. We have an algorithm that scores the responses that the patient puts in. It's rather sophisticated, but essentially it gives a high score if the patients answer all questions in ways that are bad, and it gives a low score if the patients answer questions in good ways. And each of them are weighted differently and compared to what they put in yesterday, et cetera, and on and on and on. But the practice of monitoring patients has been shown in study after study after study, and most recently one came out of Partners Health System, which is associated with Harvard, and it showed definitively that monitored patients have fewer hospitalizations, lower costs, and delayed mortality.
Right.
Delayed mortality. In fact, they did a monitoring period for 120 days of patients that had been discharged with heart failure, and during that study, 58% fewer patients in the monitoring group died.
Wow.
Yeah, the practice of, you know, a physician or clinically guided monitoring program, it's a no-brainer for the patient, for their health, for their security. And you know, who would have guessed, you know, if you would have asked me 3 years ago, is Medicare going to come out with a program that pays doctors more money? I would have been like, well, kind of bucks the trend. But if you look at it from Medicare's side, they're paying $42 a month for their at-risk patients that are responsible for 85% of all healthcare costs. You know, an average hospitalization is what, $15,000 to $20,000?
Yeah.
Well, you can pay a lot of $42 a month for $15,000 to $20,000, and I think that this initiative is going to be very, very successful.
I think once they start using it and talking among their peers and seeing the benefits of it, definitely it's going to take off. Matt, I pulled up this dashboard screen from Discharge IQ, and again, I'm just impressed at how at a glance you can see which patient needs immediate attention and kind of monitor very quickly the status of the patients who are involved in this.
Yeah, you know, and I'm happy to go over all the benefits of Discharge IQ to people that, you know, specifically want to learn about it. I think I should really only make, you know, 3 points and keep, you know, try to stay on topic to the CCM program at large. But thank you for this opportunity. You know, is that we make it easy for the patient. We make it easier for the practice to enroll the patients. We make it easy for the patients to participate, and we make it easy for the doctors to get the benefits, not only from the audit protection and the revenue side, but from the client care side. There really is, there's proven clinical value in monitoring.
Right.
And so, and you know, think of that from a physician standpoint who got into business to provide good care. This allows them to look at their at-risk population and know who needs intervention. And, you know, we're going to identify patient XYZ on Thursday who's trending poorly. We might be able to have a conversation with them Thursday afternoon rather than meeting them in the ED on Saturday morning.
And I thought it was wonderful also that the alerts can be sent to the family members as well, or whoever they need to get those alerts.
Yeah,
That's
so
great.
That it all goes back to, you know, what we do is that, so I use members of my family often as examples, and my father is the most stubborn man, most wonderful man, of course, very generous man. He has early stage Alzheimer's and dementia, but he's kind of like he's my muse when it comes to developing software.
Oh,
if
awesome.
he can use it, if he'll use it, it can be used.
Oh,
At any
great.
rate, he is. If you tell him he must do something, you can bet he's absolutely not going to do it. So we, you know, the thing goes off and he answers the questions. But if he skips, you know, when the phone goes off, you can snooze it, you can answer your questions, or you can turn it off.
Right.
And so if a patient is queried, say, you know, we need these metrics from, or we would like these metrics from you today. You know, what was your, how much did you weigh when you woke up this morning? What are the cases? If they skip that monitoring period, it will, built into the system is an alert to what we call a patient advocate. So it could be the adult child of a senior parent. It could be someone in the community, a loved one, a caretaker, that type of thing. They're going to get an alert that, hey, your whatever, your patient advocate, your patient, and we can't, you know, say the patient's name, but they'll get an email alert and they'll be able to click and go and look at it. But the idea there is to get some social reinforcement around the utilization of the product. Now, clinically, if a patient alerts, if I say that, for example, I slept in a chair last night and I'm very short of breath, and I've noticed swelling, you know, in my calves up to my knees, well, that's going to, you know, raise that patient to alert status and give, and that will actually send an alert to not only that doctor that has that patient enrolled, but other doctors that are members of the care team, if the doctor so chooses. So if I'm the internal medicine guy in Clay Center, Nebraska, and I work with a cardiologist in the nearby town of Hastings, and we're both working on the same patient, and an endocrinologist in Grand Island, those two doctors, I can sign them up as end users of the software so that they'll get read-only access to what had actually happened on the patient.
What a great
So,
connection.
yeah.
Yeah.
Patient-centric is what we call it.
Okay. So very quickly before I forget, one reason today we also had this topic and want to discuss this topic was for a lot of practice admins customers are billing companies, billing services. And we just felt it was really important for them to learn about this, to pass on this information to their clients because they can benefit from this significantly in revenue as well as caring for their patients. So I want to get that in, and we're going to go ahead and start closing this out because we're getting short on time. First of all, remind people this is the first in our summer webinar series. We have registration open now for the next month, July 22nd, and we're going to have a speaker there talking about the value of outsourcing pre-certs. And then in August, ahead of October for the ICD-10 deadline, we're going to be discussing how to partner with Dell Coding Services to help with your ICD-10 transition. And I remind you, if you are interested in learning more about Discharge IQ, you can contact us at Practice Admin, or you can contact Matt directly. I have his phone number on the screen and his website listed. And also you can contact, it's marketing at Practice Admin if you want a copy of this presentation. I have recorded the presentation, and we will have that recording available on demand as well. If you have any questions at this time, please send them to us, type them in, and I'll start reading out the questions. Are you ready, Matt?
I'm ready.
Okay.
I think.
I know we've had a good audience stick with us throughout this presentation, so that's been good to see because it's been a lot of good information out here about the chronic care management program. All
Well, I
right.
could start telling some jokes if you need a few of them.
I bet you can. All right. So first question, and I think there's a lot of curiosity around the program was just launched in January, and Matt, you're out there quite a bit. What kind of response are you seeing to participation to the program?
We are seeing slow sign up.
Mm-hmm.
I say slow sign. It's much faster than it was when I started an electronic medical record company.
Mm-hmm.
I thought that people would be literally jumping,
Really?
out of airplanes to enroll in this program and start earning this revenue. And I think just there's a healthy amount of what always happens in ambulatory care is somebody in their community has to go first.
Yep.
And so there's just, I was asked by one cardiologist that I met a few weeks ago, he said, is this legal? Because we went over I said, run a report of how many patients with chronic disease you have. And so there's that. But people are, of course, they're signing up. So we're in the early adopter phase. The thing I guess I would share with everybody about this is this is a federal program, 3 years in the making, written into 2 federal registers. There are pages and pages, hundreds of pages on this program. It is real. It is moving forward, and there is money right now on the table that physicians, if they can take the minute to get their arms around it, can really learn about it. And to back that up, Medicare also allows only one provider to bill this monthly code. It's recurring. To bill this code, only one provider of the care team can do it. So if an early moving cardiologist, and their patients are rather acute, signs up all the heart failure patients, the internal medicine doctor isn't going to be able to sign them up unless the patient revokes his consent in writing with the cardiologist and then gives it to the internal medicine doctor. So at some point, I think there will be a rush.
Right.
And we are seeing we're seeing massive interest and accelerating participation.
Right. I do have several other questions I want to get through. What is the patient responsibility portion for patients with Medicare Advantage plans? Good question.
That's a great question. So Medicare Advantage, and I was looking into this morning.
Yeah.
Medicare Advantage must provide the same benefit as Medicare. It doesn't mean they have to pay the same codes as Medicare.
Mm-hmm.
Medicare Advantage, Blue Cross in Michigan is paying for the code. But we don't have a wide variety of data on it yet.
Right.
What I can promise is why don't I get you that information so that you can update the white paper, because I have a research analyst looking into that
Mm-hmm.
today. But in general, the consultants, the big groups have said that Medicare Advantage is going to pay for it,
Mm-hmm.
but they don't have to. But the consensus seems to be that Medicare Advantage
Right.
will pay for it. So you would ask, what's the patient's responsibility?
What is the patient's responsibility or portion for patients with Medicare Advantage plans? Yeah.
And
I don't.
you know what? I don't know. I would
I'm not
assume
sure if
it's
that's
the
laid
same
out
as
yet. Yeah.
their responsibility for any other part of the plan, whether it's 20% like fee for service.
Right. Right.
Um,
Okay.
but there is a patient responsibility for standard copay under
Oh, there you go.
Medicare fee.
That was his next question. What about co-insurance or copay? Yeah.
Yeah, and I think I read that only 10% of patients don't have a supplemental or are Medicare, Medicaid patients, but this must also be in the consent document that
Right.
the patient recognizes that there is a copay.
Right. And that is laid out in some of the items within the white paper. I have information about that in there as well. And that consent form highlights it. All right, let's see.
Go ahead.
What is I think it's just 8.00 fee, and what is the cost for the patient-centric to provider? I'm not quite clear what that means.
Can you repeat the question?
I'm not sure if she means $8 fee, and what is the cost for the patient-centric to provider?
So the co-fee is 20%.
Yeah, she said
so
yes,
it's
$8 fee. Okay, I'm sorry, go on.
$8.52, I think.
Yeah.
It shouldn't do math that fast. Might get a headache. But that is the patient's portion.
Okay.
Of course, a lot of billing systems will just pick that up and subsequently bill it. There is no fee for patients to download the app and start using it. There's zero fee. So a patient, you're in your doctor's office, the doctor says, hey, I want you to do this.
Mm-hmm.
The app is a free download. Now, in order for them to actually be monitored by their doctor, when they download the app, they have to use the username and the password. And at practices, what they usually do is an MA will sign the patient up, right there with them, download the app, put in their username and password.
Right.
And then it will start working, according to the protocol.
Okay.
Possibly later on that afternoon.
Yeah. So we do have someone here asking about the pricing for Discharge IQ.
So thanks for bringing that up, because I'm never unclear about pricing, but I have to be unclear in this particular case.
Right.
Cardiologists typically enroll many, many more patients, so they have a higher monthly fee, internal medicine, and then lower for family physicians. But it depends on the individual practice. I can tell you this: we will never be more than 25% of the revenue we generate for the practice.
Right.
I feel called to be in this business. I think the family practitioners in particular need some help, and so we want to be a reasonable rate. At the same time, we got to keep the lights on.
Yep. Oh, okay. We've got another great question about. Let's see. We are already doing care plan oversight for patients under home health care, and they have chronic diseases. Can we accumulate the 20 minutes required after the 30 minutes for the CPO and still charge for CCM? Great question.
Patient, yeah. So and I think you said doing home health care?
Yeah. Oversight for patients under home.
That are receiving home health care are exempted from the program.
Okay. Unfortunately, yeah. I think I remember reading that.
If that brings up also, though, patient-centered care plans are also part of patient-centered medical homes.
Right.
PCMHs, this is not exempt. ACOs and patient-centered medical homes are eligible for reimbursement, and it's beneficial in two areas. You will see quality improve with monitoring so that your reimbursements will be larger in the future. You'll also get the additional monthly recurring revenue from the enrollment base.
I wonder if if that may change in the future once the program starts being tested. We'll see.
Well, here's what I would say about this. You can expect a lot of changes.
Yeah.
I don't think that will change. I don't think that will change. I think what will change is the minimum requirements. So, for example, and this is, and I want to take this opportunity to point this out to everybody. This is $17 billion a year on the table that Medicare is putting out there. There's 3 commas in that number. So there are going to be vendors and promises and things coming out of the woodwork to try to capture some of that money. If you'll remember the big EMR boom, that was a $29 billion initiative sponsored by the federal government to get doctors to adopt an EMR. And they were everywhere. Or office managers getting 27,000 phone calls a day. But not really. But this is $17 billion this year and next year and next year and next year. And there's 10,000 patients becoming Medicare patients every day, baby boomers. So there's going to be all kinds of stuff. So what I think we should be expecting is that the requirements are going to tighten up a little bit. And so if you spent 20 minutes, you better not have it documented that the 20 minutes you spent was, well, we spoke for 7 minutes about, Mrs. Johnson's grandson in California who's going to climb K2.
Right.
Remember, the core of this program is to reduce hospitalizations for patients at risk, for chronic care management. So sooner or later, that you're going to have to get a little bit descriptive on what type of things are being put in place. So the care coordination program is pretty well outlined.
Yeah.
But I would want to just warn everyone, or make sure that everyone is thinking about how does this really get to the heart and soul of chronic care management. I met somebody from a vendor the other day out of California, and they have an app that they sold to large self-insured organizations that helped their employees meet their fitness goals, their nutrition, weight loss goals, and their smoking cessation goals. And so that didn't go really far. I admire it. I think it's a great thing. Employees will be more productive and your healthcare costs will go down. Well, now, guess what? You run that company and you're struggling to kind of get it there and make it the next big thing, and all of a sudden Medicare says, hey, there's $17 billion on the table. So they added a call center with nurses and say, yeah, and if we're going to still give you this nutrition guidance and help you keep your exercise goals and your weight loss goals and your smoking cessation goals, and we're going to document that we interacted with you for 20 minutes.
Yep.
Well, that makes me nervous, because now you're bringing, okay, so I'm outsourcing my care. I don't like the concept of call centers. I don't want to outsource or encourage my doctors to outsource their care. And then their fee was $30 per patient.
Wow, yeah.
They say, well, and you'll get $13, $12.60 per patient. Well, it might be $4 by the time you don't get the copay. And then at that point, you start to wonder, is it even worth it? But hiding behind that is the risk, and it's the doctor that owns the risk, not the outsourced vendor. It's the doctor that owns that risk. And if Medicare can come back and say, all right, who did it? A nurse? Where is she? California. All right, well, you're in Alabama. Is she authorized to provide nursing services in the state of Alabama? Okay, now you don't just owe us a little bit of money. You owe us 3 times the amount of money you billed us for this.
It brings up a lot of interesting questions about the future of this program, and I think we're all going to be keeping an eye on this. I had one last question, and I'm going to have to cut you off. She would like to know what facilities can be referenced today that are using Discharge IQ.
we have several references, and
Okay.
just contact us, and we will
Right.
talk to them. Internal medicine, cardiology. We actually have a world-renowned cardiologist,
Wow.
and the internal medicine doctor that I talk about is a great great-great-grandnephew of Albert
Oh,
Einstein.
really? Wow, fascinating.
Yeah.
Very
It's
interesting.
not fair. He's a good-looking guy. He's related to Einstein. He's a doctor. Like, some people have all the luck.
Boy. Well, Matt, I want to thank you for joining us today. Very interesting topic, and I feel like I've learned a lot from this. I know there's several questions that we were not able to get to today, and I was going to encourage you, you can contact Matt directly or contact us at Practice Admin if you have any further questions. And to remind you again, we have more webinars lined up every month for the next several months. And this is Tamara Hyatt with Practice Admin and Matt Ethington with Discharge IQ. Thank you, Matt. I'm glad you could join us today.
Well, I thank everybody for their time. Thank you, Tamara.
And again, this will be recorded, and you can send me an email at marketing@practiceadmin.com if you'd like a copy of the PowerPoint. Thank you, and have a good day.
Thank you.